All right, well, I'll just start by introducing Bill. So good morning, everyone. Welcome to Cardiac Sciences Grand Rounds. And it's a pleasure to introduce Dr. Bill Mcintyre. I've known Bill for quite some time now. He's a cardiologist. He's a native from Fredericton in New Brunswick. He did his medical school internal medicine residency at Queen's University, where he was actually mentored into research by one of my former trainees and mentees, Dr. Adrian Baranchuk, who did a great job with mentorship with Bill. He finished his cardiology at the University of Manitoba, and then I actually recruited him as a fellow at the Arrhythmia Service in Hamilton at McMaster, and then I moved here. But Bill has been there since 2016. He's done a great job. He's both enrolled in the clinician investigator program at McMaster, so he is finishing his PhD in health research methodology, and at the same time doing his clinical EP fellowship. Been quite productive during these last 4 years. He holds the Canadian Institute of Health Research Award, Canadian Stroke Prevention Intervention Network, the C-SPIN Award. He's holds research grants from CCS, Atrial Fibrillation Awards. So for a young career, early career, he's been quite accomplished, has over 80 publications in PubMeds, and has been working quite a lot in interesting topics called atrial fibrillation occurring transiently with stress, which will be what he will be talking today. His last accolade was that at the CCS meeting, at the Canadian Heart Rhythm Society meeting, he was awarded the best abstract by a trainee, and he presented that last Saturday. So it's a pleasure to have Bill here. He's applying for one of the jobs here in EP, and he's an academic cardiologist. So Bill, thanks for being here.
Thank you so much, Carlos, for the introduction. My friends, thank you for joining us this morning. I think that we know so much about atrial fibrillation, but I think that there's so much that we have left to learn. And I hope today, this morning, in the time that we have together, to be able to show a little bit of what I've learned over the last few years with you. This is what I call atrial fibrillation occurring transiently with stress, or for short, AFOS. I want to introduce you first to a patient to frame the conversation. This is my make-believe friend, Walter. He's 70, he's got hypertension, diabetes. He has no history of any heart disease, but there's been strokes in his family. And if you talk to him, living stroke-free is one of his greatest priorities. You meet him as a cardiology consultant because he's in the hospital for 5 days with pneumonia. And for the first time ever in his life, he has atrial fibrillation on and off for 48 hours. All he gets is a little bit of beta blocker, and as his oxygen requirements come down and he's up and moving around, his atrial fibrillation is gone, and there's none for the last 48 hours of his admission. You're getting ready to send him home, and you ask yourself, should I offer Walter oral anticoagulation to reduce his risk of stroke? And if so, for how long? Or should I be doing something to look for more atrial fibrillation in Walter to convince ourselves that he really does have atrial fibrillation? What if instead of Walter, we have Vera, a little bit younger, hypertension, but again, no family history of heart disease, a history of stroke. You meet Vera when she comes in for cardiac surgery. She has a 6-day admission for simple coronary artery bypass grafting, but like so many patients, she has rapid atrial fibrillation on post-op day number 2 in the ICU. She runs on an amiodarone drip for 24 hours. She converts, is flipped over to oral amiodarone, and we don't see any more atrial fibrillation in the admission. Is she any different than Walter? Do you offer her oral anticoagulation? For how long? Should you have to look for more AF? How long might you wait to do that if you did it? Another patient, Ron. Ron's 68, and he has heart failure with preserved ejection fraction. He has an elective total knee arthroplasty, and on the first post-operative day, he has rapid atrial fibrillation for 24 hours, and he's perceived to be hemodynamically unstable, so he actually gets an electrical cardioversion. How should we treat Ron? Oral anticoagulation? Do we look for more atrial fibrillation? And then finally, Sally, 75, and her very first encounter with any heart disease is a 4-day admission for an acute coronary syndrome. Now, interestingly enough, she presents with no palpitations but chest pain and is in AF for the first time ever in her life. And whether it was just time or the magic of PCI, her atrial fibrillation resolves before she's discharged from hospital, totally spontaneously. So again, with Sally, does she need oral anticoagulation? For how long? And do you look for more AF? I've shown you 4 different patterns of patients and backgrounds where you can have new onset atrial fibrillation with another primary intercurrent illness. Some of them cardiac, some of them not. They've all had different patterns of their atrial fibrillation, and they've all gotten out of it in different ways, some spontaneously and some with intervention from the physician. There's so many things to think about when we want to stratify somebody who has atrial fibrillation in these settings. Meanwhile, if you were to look at Twitter, and if you happen to follow someone like Medical Axioms, well, they might just say this: new onset AFib in hospitalized patients has the same differential diagnosis as sinus tachycardia. It's not so much a rhythm disturbance as a rate compensation. Really, don't worry about it. Or Wayne, who goes by Toaster Pastry, says people treat AFib as the disease, but it's really just an innocent bystander. Clearly, neither one of these 2 physicians are really particularly worried about atrial fibrillation that presents this way. My objectives for this morning is I really want to show you all the uncertainty that surrounds atrial fibrillation that comes in for the first time in the setting of a transient physiologic stressor, such as acute medical illness or surgery. This is atrial fibrillation occurring transiently with stress, or AFOS. I'm going to show you the existing data around the incidence of AFOS, the recurrence of AFib months after a hospitalization, and I'm going to show you why the data is problematic. I'm going to show you the work that I've been doing and then have some suggestions for how we can do research and what we can implement now to improve care for patients with AFOS. These are my disclosures: speaking fees, research funding, and I will show a product that I have a health label, a Health Canada investigation that's a Holter monitor. So what are the facts? I said we know so much about atrial fibrillation. The things we like to tell our patients: that your lifetime risk of atrial fibrillation is 1 in 4. And it's so important to us because it's a major cause of death and disability. It's responsible for 15% of all strokes and 30% in those over 80. And the risk, fortunately, is modifiable with oral anticoagulation. And that's why we work so hard to find it and to get patients safely on drugs. We can cut that risk of stroke by about 2/3 and the risk of death by about 1/4. But one of the challenges with atrial fibrillation is it frequently shows up for the first time in the setting of an acute physiologic stressor. This is atrial fibrillation occurring transiently with stress, or AFOS. Let me walk you through a little bit of how this problem works. So if you can imagine, you have some patients who've never had atrial fibrillation in the past. Now, they're subjected or experience acute physiologic stress. An infection is commonly it, and it's surgery, whether it's non-cardiac or cardiac. And while that's happening, there's actually 3 sets of interesting things going on. The patients may have fixed risk factors. They have some degree of structural heart disease. It could be valvular disease, comorbidities like hypertension or diabetes. And it may cause some degree of atrial myopathy, an atrium that's not normal, whether it be in size or histology. When you're sick, you have a whole bunch of different transient risk factors. There could be ischemia, metabolic changes, your potassium's up, it's down. There's inflammation, sometimes all through your body, sometimes directly in the heart. Your sympathetic nervous system gets primed up. And in the setting of cardiac surgery, well, there's direct cardiac injury. And the thing about patients who are under stress and they're sick, they're hospitalized, so their vitals are being done all the time, and they get continuous ECG monitoring. And what we find, not infrequently, is that patients with another primary illness frequently also present with new atrial fibrillation. And what we also see is that as stress resolves and whether we do our interventions, sinus rhythm frequently comes back. And we're left asking ourselves, does this patient in front of me have atrial fibrillation? Or is what we've seen here just secondary to a reversible cause, uniquely and directly so, and therefore it's benign? Or have they just told us, doctor, I have paroxysmal atrial fibrillation and I need all of the intercurrent evidence-based care that is shown to improve outcomes for these people? Atrial fibrillation occurring transiently with stress is the term that we've coined. And so that we're very clear what I'm talking about. So it's the patient with AFib, no prior history. They're hospitalized for another primary acute medical condition or surgery. And importantly, they go home in sinus rhythm. It's transient, whether that's by the hand of the people caring for them or if it's spontaneous. Elsewhere in the literature, this is called secondary AF, perioperative AF, provoked AFib, AF with a presumed temporary cause, AF with a reversible cause. But I try to stay away from most of these terms because other than perioperative AF, they tend to make the assumption that it's a reversible and benign process that we can forget about. And that's really why this issue is significant. We don't know, and it may be different in different patients if this is a benign phenomenon or if it's the first presentation of paroxysmal atrial fibrillation. So if we think about AFOTs, there's a couple of important questions we might want to know the answers to try to sort this stuff out. So the first, of course, is we see patients with stress and AFib, and when it goes away, they're back in sinus rhythm. Well, the first question is, how frequent is this particular problem? So in order to try to crack that nut, we did a systematic review and meta-analysis of the literature. We actually did 2 of them, and to show you here the acute medical data, excluding cardiac conditions, a lot of sepsis, pulmonary embolism here. One of the most difficult searches I've ever done, because you can't put physiologic stress in as a medical subject heading, but by building a long list of candidate conditions, we got about 12,000 citations, pruned it down to 36 studies on incidence of atrial fibrillation. And here's what we saw in the forest plot. I think you'll notice very quickly that these data are all over the place. And in fact, the incidence of new onset atrial fibrillation in medical illness is anywhere from 1 to 44%. That is to say, it's either rare or so common that every second person has it. And frankly, it's really confusing. And of course, I couldn't try to put that all together and give you some kind of a weighted mean average because there's absolutely no overlap in any of this. The I-square statistic for heterogeneity, as I've circled, is 99%, all over the place. So this is not terribly informative. Now, one thing that was a little bit informative is we predefined some criteria for what the perfect study would look like looking for atrial fibrillation. And you can imagine if you really wanted to see what was there for atrial fibrillation, you'd want continuous monitoring and systematic ECG review in a prospective study. Anything other than that really would be substandard, and there's a good chance that it's going to be subject to some kind of a detection, intervention, or a recording bias. So we really see there's only a handful of 6 or 7 studies that showed that there was continuous monitoring and with systematic ECG review and a little bit higher incidence of atrial fibrillation in those studies, but certainly not enough to explain all of the variation that we see. We did take a look at the risk factors, and we found a whole smorgasbord of things. Things that we saw over and over again were multivariable associations with age, being septic, being Caucasian, being obese, using vasopressors, having an infection, or having acute organ failure. But of course, due to the nature of these studies and study level data, we can't really prune these down to nail the risk factors. Let's look at cardiac surgery on the other hand. So we've also reviewed that. After sorting through 40,000 citations, we ended up with 345 studies to inform things. So this one I'm going to show tabularly. So first you'll notice that when it comes to the high quality studies with continuous monitoring, it's only a small minority of about 27 studies that looked the way that you would really ideally want to look for atrial fibrillation. And what we see here, so we drop this down by different types of surgery, is clearly in the surgeries that thoracic surgeons do. There's incidences of atrial fibrillation up somewhere in the teens, and then vascular surgery a little bit lower, and then other surgery lower as well. But you still see, even in these higher quality study designs, really wide ranges in the incidence of atrial fibrillation, in some cases 8 to 9-fold variation. So again, really a lack of clarity and how much atrial fibrillation is out there. And if I limit it just in this forest plot to all of our high quality studies, each horizontal line separates a different type of surgery. You can see there's a bit of a gradient again as you go down from pulmonary surgery, esophagectomy, other thoracic surgery, vascular surgery. But again, there's really marked variation even in these continuous monitoring studies. So it leads you to believe that there might be some other factors at play, or maybe the monitoring's not being done quite the way that you might hope it would. So if we summarize what we learned from the previous literature about the incidence of atrial fibrillation occurring transiently with stress, there's really wide ranges, anywhere from 0 to 50%. So almost nobody to every second person that comes in the door. And the two things that we noticed is that the severity of illness may not impact incidence really to the degree that we thought it would, but maybe the monitoring strategy appears to have some impact. And what this did is tell us we need to get some better data. And it informed the design of our atrial fibrillation occurring transiently with stress incidence study, where we really tried to nail down in critically ill patients how common is atrial fibrillation occurring transiently with stress. So here's what we did. We blitzed the ICUs for all the new admissions. Anybody who was coming in with medical illness or non-cardiac surgery and had one CHADS risk factor, but clearly had no past medical history of atrial fibrillation after a thorough chart review, got one of these Zio patch monitors put on. And we did that within 90 minutes of them coming into the ICU 24 hours around the clock. We were grateful to have a deferred consent model to be able to do this, and then the chance to circle back on patients and their families when some of the initial emotion and dust from the initial admission had settled to chat with them about participating in the study. We saw them every day, and we looked for clinical events, and we looked very carefully to see what the hospital telemetry had captured for atrial fibrillation and what physicians and nurses had put in. Patients kept these patches on for 14 days or until they went home. We followed them up for 30 days or until the end of the hospitalization. And what we were looking for was at least 30 seconds of atrial fibrillation. And again, why we did this? So we used a Zio patch monitor because it's a simple thing to be able to use. We can get 14 days out of monitoring. We get single lead with wonderful atrial fibrillation algorithms. And really, this is the gold standard. So this study protocol, and the next one I'm going to show you, because it was prospective, systematic, and prolonged, it's sensitive for picking up atrial fibrillation. And it has distinct strengths over what's been done in the past, primarily retrospective, opportunistic, maybe a shorter duration 48-hour holder. So here's what our patients look like. They had a median age of 71. About a third were female. The median CHADS-VAS score was 3. The Apache 2 score, which is basically our ability to put how sick they are on a continuous scale, was 16, and the BMI was just slightly above average. 2/3 of these patients had non-cardiac medical illness. A third of them had non-cardiac surgery, and the remaining handful were trauma patients from the trauma ICU that we saw. So I'd like you to take a second and guess, how common do you think new onset atrial fibrillation is in critically ill patients in the ICU if they're attached to a sensitive Holter monitor? And if you guessed about 1 in 5 or 20%, I'd say that you're right. And that was the incidence of atrial fibrillation lasting at least 30 seconds. And we designed our study to have a confidence interval of plus or minus 5%, because we think that that really allows us to hone down on something practical and useful for sample size calculations otherwise. And you can see here how the incidence changes. Of course, it goes down if you set your criteria for longer durations of atrial fibrillation. In terms of how the atrial fibrillation behaved, the median heart rate was really sort of at that tachycardia range at 114. 75% of patients hit a heart rate of 164, That's the lower interquartile range in the middle bar there. And they spent about half of the time that was in AF being tachycardic at a rate of 110 beats a minute. Now, one of our big secondary objectives was to figure out how commonly it was that the clinical team would recognize atrial fibrillation, and that turned out to be 70% of the time, either a nurse or a physician documented it in the hospital record that there was atrial fibrillation, or if you want to turn that on your heads and be a glass half empty sort of person, you could say they missed about a third of cases. And this table shows sort of the difference between the atrial fibrillation that was seen and the atrial fibrillation that was missed. Now, of course, it's not surprising that patients who had atrial fibrillation detected by the clinical team had higher burdens or percentage of the time in AFib. They had, of course, longer durations of AFib. Their longest single episodes tended to last longer, and they trended towards having more episodes. Although, interestingly, the time to onset was a little bit longer overall. And here we did univariable regression just for power considerations to look at things that predicted atrial fibrillation. So the first four, of course, are 1 point on a continuous scale. The older you were, the sicker you were, had weak relationships. Your CHADS VAS score actually had a reasonably strong relationship. The log of your high sensitivity troponin or your myocardial injury. And then one thing that may jump out is having to use vasopressors or inotropes. Now, you may think of that as a proxy to illness, to be so hemodynamically disturbed. But we have shown in the past that being on vasopressors or inotropes, and specifically the combination of adding vasopressin to catecholamine to reduce adrenergy, actually there's strong evidence that that reduces the new onset of atrial fibrillation in patients with vasodilatory or distributive shock. So if that's where we kind of think the incidence is, at least in the critically ill patients, what other kind of questions would we want to ask? Well, if we're trying to predict the future for our patients with AFOTs, if you had a secondary and a benign course, you should probably have a comparable long-term prognosis to other hospitalized patients. But if you really have atrial fibrillation, you should have a higher risk of stroke, heart failure, and death. So we tried to look at the long-term rate of stroke. And again, what we did was we rigorously, systematically reviewed the literature. Now, just to be clear, I'm talking about non-cardiac surgery here, and these are the long-term risks of stroke. The first green bubble, what you'll see is that risk of stroke was about 3 times higher, relatively speaking. Now, the heterogeneity is quite wide, but it clearly tends toward an effect. Really, what we're trying to argue or uncertain about is the magnitude of the effect. But at the bottom, this is important where it's always critical to look not just at relative risk, but at absolute risk. So the absolute risk for a stroke 30 days after a hospitalization for non-cardiac surgery complicated by new onset AF is 1.5 per 100 patient years. And if you're familiar with the literature, you will know that that is exactly where the CCS set the bar in terms of an absolute risk of stroke that may justify any risk associated with oral anticoagulation. So we're sitting on a relatively thin margin here. But there's one other thing that's interesting. If I take those numbers away, and if you happen to be sitting on your calculator, and you look, the crude risk ratio here for the rate of stroke in comparison is 1.65. And that is not even within the confidence interval generated by a random effects meta-analysis. That's called Simpson's paradox, and that tells you that these data have marked underlying confounding. Now, the ESC recently gave out a 2A recommendation based mostly on these studies for oral anticoagulation after non-cardiac surgery. And in my mind, I think that's entirely not justified based on the data that are here. So the next important question. So if we can't really rely on the long-term data in terms of risk of stroke, well, we know that these patients probably, if they have AFib, it should recur at some point. So we look at the literature and say, hey, what is the long-term rate of atrial fibrillation recurrence in these patients after their discharge from hospital? So we had looked at that in our medical illness review, and we found that really there were only 2 papers out there that had ever looked at that. The light gray one was from the Framingham Heart Study. So they did have systematic follow-up, but they did that basically saying, hey, have you ever had atrial fibrillation again on a 12-lead EKG? Systematic, but not necessarily super rigorous. But up to 5 years, they found that about 2/3 of patients with AFOTs and some sort of presumed secondary cause of their atrial fibrillation managed to have atrial fibrillation again. And they saw a very similar signal when Waukee looked at administrative data and looked at survivors of sepsis, finding that at 5 years, again, about half of people with atrial fibrillation are having another claim where they're actually having atrial fibrillation again. These data are the data for long-term recurrence after non-cardiac surgery. First, I want to highlight the methods. So these are almost all retrospective administrative data, non-systematic search for EKGs. The numbers are all over the place. But there's one study in here that I think really used what is ideal methodology, is that they grabbed patients prospectively and everybody got a 14-day Holter, and they found that 30% of the time patients recurred with atrial fibrillation after having it for the first time after surgery associated with oncology. So these data have informed our design of the atrial fibrillation occurring transiently with stress follow-up cohort study. And this is how this works. So we take as cases patients with new atrial fibrillation with illness. We have a cohort of non-cardiac surgery and a cohort with medical illness. And each of these patients must be candidates for oral anticoagulation by the CCS algorithm. And what I mean is they must have at least one of the CHAD 65 scores. We grab controls. So this is a matched cohort design. These are patients with no new onset AF who are matched for sex, age, and the hospital service so that we're getting similar patients together. And of course, they have to be candidates for oral anticoagulation. We're not taking anybody with a prior history of atrial fibrillation. We're not taking anybody who went home in atrial fibrillation. And we're not looking right now at the cardiac population. So here's how this works. We screen the hospital wards every day from the telemetry. We look at the new admissions and their ICUs, and we're looking for patients with new evidence of atrial fibrillation. We collect their baseline data, and the investigational part of the study is at 1 and 6 months, they were a 14-day patch ECG monitor that we've set up all through a virtual study, which we've had to adjust to keep things going during COVID. We see them at 12 months, just look for their medical history and any events outside the study. And what we're looking is to see if there's any recurrent atrial fibrillation on their monitors, or if they've managed to have atrial fibrillation detected outside of the study protocol. Our hypotheses are that patients who had AFOTs are going to have a higher prevalence of AFib as compared to the controls when we screen at 1 and 6 months. And we're actually expecting to find so much AFib after AFOTs that you could make the argument that maybe we actually don't need, that all these patients might be candidates for oral anticoagulation out of the gate. So these are the baseline demographics of patients from the pilot phase. Mean age was about 75. The percentage of female patients was right around 50, which is higher than most studies in cardiology. They have a median CHA2DS2-VASc score of about 3. They were in atrial fibrillation for about 15 hours at a time, and then half of them cardioverted spontaneously, and then half of them cardioverted by the hand of a physician. The proportion that were discharged on oral anticoagulation was just under half. And where we are with this now, we enrolled the final case patient earlier this month, and because there's a 1-month lag, we're 90% done on our controls. So we should have our follow-up done fall next year, and I hope to receive some study results from Santa Claus for Christmas. So looking back at if there's another way we can answer this question of what's our long-term rate of atrial fibrillation recurrence? Well, if you had a patient who has stress and atrial fibrillation and it goes away, wouldn't it be great to look into the past to see if they had a prior history of paroxysmal atrial fibrillation? And there's actually one population of patients where we do know their heart rhythm history all the time. They're near and dear to many of us. Those are our pacemaker patients. So what we did in ASSERT, if you're familiar, which was a large clinical trial of 3,000 patients where every heartbeat and every run of rhythm was adjudicated over about 3 years of follow-up. So we took all these patients without pacemaker and a history of atrial fibrillation, and we compared the prevalence of device-detected or subclinical atrial fibrillation before and after a hospitalization for non-cardiac surgery or medical illness. So if you look at that gray plot in the middle of the screen, imagine each one of those patients is somebody, each one is a patient, and every blue bar is an episode of atrial fibrillation. Well, what if right at that line there, we said that was the date of hospitalization? I think that if the data look like this overall, and this is just theoretical, I'll show it to you in a sec, you might conclude that there's probably more atrial fibrillation at the time of a hospitalization, but that's certainly not the only time patients have atrial fibrillation. So here's what we saw. So the first thing to show right there in the red bar is that 10% of patients with a pacemaker and without a history of atrial fibrillation have at least 6 minutes of AFib in the month immediately following a hospitalization for medical illness or non-cardiac surgery. And that's higher than at any other time. But as I peel this away, you'll see that the background rate of atrial fibrillation in these patients is actually relatively high. So we can conclude by looking at this, that there's a clear increase or spike in the incidence of pacemaker-detected AFib at the time of hospitalization. But you'll wonder if there might be more going on in the background. So what we did is we did basically a nested case control looked in that and asked the question, if you had atrial fibrillation in that 1 month after your hospitalization, how likely were you to have had it in the past? If we look into the past, we know that that's unbiased because there's no treatment that's been done there and everybody's monitored the exact same. So it turns out if you had 6 minutes of AFib, exactly half of those people had prior atrial fibrillation, and you had 7 times the odds of having it. But if you look to longer episodes of 6 hours or 24 hours, it was more around 2/3, and your odds were in the 30s of having had something in the past. So what we concluded from this data is that 1, device-detected AFib increases around the time of hospitalization and totally unbiased monitoring, and that half of these patients had prior history of device-detected AFib. This absolutely says that new onset atrial fibrillation that occurs as a secondary diagnosis cannot be dismissed. But with rates exactly around 50%, we cannot go all the way either. So we can't say that, you know what, all these patients have a high enough rate to justify the routine use of oral anticoagulation. Now, I'm sure there's some cardiac surgeons in the crowd, and you guys are probably asking, hey, what about my patients? You're talking about medical illness, you're talking about non-cardiac surgery. And I think you're quite right to be concerned, because in the setting of non-cardiac surgery, new onset AFib all comers is 1 to 5%, but in cardiac surgery, really depending exactly on the surgery being done, it's anywhere from 1/5 to half. So we've actually started more recently to look at these folks. We started with a systematic review and meta-analysis of the existing literature to find out if the data were any good. So here, again, we're talking about cardiac or heart surgery. And what we see here is that patients with perioperative AFib have a higher short-term risk of stroke. And when I say short-term, I mean in hospital or up to 30 days, depending on how they study it, which is about a 3% overall incidence and is actually relatively high. But if we look at the long-term incidence of stroke, this is again beyond initial hospitalization or 30 days, again, the relative risk is high, sitting around 1.39. But what we see, again, is that the absolute risk of stroke in these patients over the long term is only 1.6 per 100 patient years. Again, you're sitting right on that margin where the risk-benefit ratio for oral anticoagulation by typical standards is you're kind of straddling the line. So let's go back to our schematic. This time we're talking about cardiac surgery. So we have our patients without AFib, they undergo cardiac surgery, and whether it's with time or intervention, sinus rhythm comes back. And really there's two possibilities for any given patient. They have chronic AFib, and when I say chronic AFib, I mean paroxysmal, persistent, or permanent, the disease that we talk about in our guidelines and we have our big evidence base for, or there's no AFib and it's a reversible cause. And if you think about that, that's really two potential phenotypes. And what we're starting to ask right now is if there are potentially two different perioperative AFib phenotypes, well, maybe there could actually be perioperative AFib genotypes. There's been a movement in the last few years with genome-wide association studies becoming cheap and widely available that polygenic risk scores that show SNPs, SNPs, or single nucleotide polymorphisms, that small collections of these and patterns above what's expressed in the population can predict incremental risk for incident atrial fibrillation in multiple different cohorts. And this is actually adjusted for anything you can think of in terms of traditional predictors for atrial fibrillation. So we're actually trying to harness this power. So far, people have only looked at this for incident and prevalent AFib, but our goal is to actually look at this for post-operative atrial fibrillation. So we're working in the Vision Cardiac Surgery database. In Vision Cardiac Surgery, there were 4,000 patients at 24 sites in 12 countries that gave a preoperative whole blood sample. And from that, there were about 1,500 patients that had new onset postoperative atrial fibrillation. There were 572 that had atrial fibrillation in their past medical history, and the rest of them had no history of atrial fibrillation. We're going to do polygenic risk scores in these patients and do two nested case control studies to look for a signal there to see whether the polygenic risk scores associated with new post-op atrial fibrillation are the same as prevalent atrial fibrillation, if they're different from people without atrial fibrillation, or if they actually happen to sit somewhere in between. And we might be able to use this to actually risk stratify some of these patients. It has opportunities all along the perioperative journey for prophylaxis, treatment in hospital, and both the long and short-term stroke prevention. So the last thing I kind of want to leave you with is a little bit in terms of some practical tips. This is what I've been doing to manage patients with perioperative atrial fibrillation in my practice. And I think that what you'll see is actually pretty similar to what the algorithm put out by the ESC guidelines recently looks like, although I would say that this is not fully evidence-based, but it's evidence-informed. When it comes to rate and rhythm control, it is important to treat the underlying illness, and whether you're going to choose rate and rhythm control should be guided by hemodynamics and patient symptoms in the acute phase. Oral anticoagulation is a complex decision for patients. Giving them 3 months upfront as if they had been cardioverted is often reasonable, and we're going to be more likely for oral anticoagulation. The higher your TRADS-VASc, the more AFib you had, if you had to be cardioverted, if you had multiple episodes of AFib in hospital, or if your atrium's bigger. If you don't choose long-term, if you don't choose antiarrhythmic drugs, I think we can Holter these patients 4 weeks post-discharge. I recommend 14 days of Holter monitoring. If they're in sinus, I think it's probably reasonable to stop their therapy and reevaluate. For persistent AFib, I either will arrange for cardioversion of these patients or accept permanent AFib. And if they do have recurrent paroxysmal atrial fibrillation, I would put these into the same pathway that I would for a patient with a new diagnosis of atrial fibrillation. Now, this is cardiac surgery. So cardiac surgery, in our hospital, we are aggressive with rhythm control, and we tend to load IV amiodarone because that's the most efficient way to get it in our hospital, and we can do it on the cardiac surgery ward. And we start to fast our patients 24 hours after the onset of atrial fibrillation if they haven't converted, and then would consider direct current cardioversion if they're still in AFib. Going home, we use the loads that were shown in the Gilinov rate and rhythm control trial. We do sort of a half load of 3 to 5 grams of amiodarone and stop it 3 weeks out. If they're an AFib that's been rate controlled, we'll do a full load of amiodarone. See everybody with a 14-day Holter again, 8 weeks post-discharge. If they're in sinus, they can usually stop therapy for what we think is persistent AF, we'll cardiovert, and if they have recurrent AFib, we manage like new non-operative atrial fibrillation. When it comes to oral anticoagulation, this is a lot more complex. This is individualized. We consider a lot of the same factors that we do in patients with non-cardiac surgery, but the more AFib they've had, the more we think they have a propensity to atrial fibrillation, and the higher CHADS VAS score, the more likely we are to anticoagulate these patients. But this decision is much more interdisciplinary. Cardiac surgery has a much higher inherent bleeding risk than any other surgery. So we attack this in a multidisciplinary fashion, chatting with the surgeon who did the procedure, with our local thrombosis experts, and then for arrhythmia. And we're cautious with our choices. In highly selected patients, we will use dabigatran because of the reversibility. And we are actually putting in a grant to pilot a trial to do VKA versus DOAC with a non-inferiority for bleeding design. And we're hoping to be able to get that off the ground to figure out the right oral anticoagulant choice in the short term for 1 to 3 months following surgery. So the things that I think I've told you this morning, and I want to conclude, I think that there's really a lot of uncertainty about how to treat patients with atrial fibrillation that occurs transiently with physiologic stress, or AFOTS. The published estimates on the incidence and recurrence vary widely, and I think that this really has to do with the different populations and the methodology. In the AFOTS research program, we've tried to generate sensitive estimates of the incidence and recurrence of AFOTS. And I think that harnessing the power of genetics, in addition to just remonitoring patients, may really help us to differentiate between benign and pathologic presentations of AFOTS. I want to thank everybody who's been helping me throughout my PhD. Jeff Healy and Rich Whitlock are my supervisors. And of course, Rory, who is the official mascot of the AFOTS research team. Thank you guys so much for having me. I wish that we weren't stuck virtual and digital so that we can chat after, but I do look forward to hearing what questions that you have now. Thanks.
Thanks, Bill. That was a great presentation. Let me ask you a couple of things before we go to some of the questions. So I was a little bit surprised by the incidence that you reported. It was about 18%, which I think is kind of low. Because if you look at the ASSERT-2, these were people over 65 with, one risk factor being obese or something like that. And it was about 30% in that group. Of course, a little bit of a longer follow-up. But so my question is, how much does really stress increase the risk of atrial fibrillation? And the other thing that I noticed was that there was only about 5.3% that had AFib greater than 24 hours. And if you believe the data from ASSERT-1, in which really the people that had an increased risk of stroke were the ones that had AFib greater than 24 hours, maybe that should be the population that we target for anticoagulation when you follow them up. Or is it the duration, or is it burden of AF?
Yeah, so I think that's a really great question, and I think a lot of the ways that we care for patients with atrial fibrillation occurring transiently with stress are informed by what we're seeing in subclinical atrial fibrillation. So the interesting thing is that I didn't show it specifically. You said that you were surprised by the incidence of atrial fibrillation in the ICU. Coming out around 18%. It ended up being exactly what we estimated when we pooled all of the studies, both high and low quality, that were in the ICU. So it's interesting how varying research designs can regress to the mean. So, and I think that one of the biggest differences is in ASSERT-2, like you mentioned, and the other studies like PREDATE, which we've actually just completed individual patient data meta-analysis on. Those studies did show higher incidences with longer monitoring. But I'm actually going to show you a little sneak peek at a data here. So this is when we actually simulated 14-day Holter monitors in patients in ASSERT. So something that actually maybe is more similar than a 14-day capture like we did in our studies, and it's why I like 14-day monitors. We found if you simulated 14-day monitors in ASSERT, the proportion of patients with 6 minutes of atrial fibrillation, which was sort of the cutoff in that study, was around 3%. So it's certainly lower than what we saw in the ICU population. And the stroke risk associated with that was 2.2% per year. I think that it becomes very, very hard when we peg down a minimum clinically important duration of atrial fibrillation because there's such big differences in the denominators. Of course, ASSERT looked at 24 hours over the course of 2.5 years of follow-up, and this is looking at 6 minutes over 14 days. But and I think this is one of the reasons that when you're not selecting your population, you really need to be careful and prove oral anticoagulation works in some of these people.
Yeah, okay, great. There's a question about new AFib and congenital heart disease post-cardiac surgery. How frequent would he do?
So in congenital heart disease, that's tricky. Certainly those are the ones where we involve our congenital cardiologists over the long term. And the question I think always there is, are you willing to consider the congenital abnormality, whatever it may be, equivalent to give you the C in a CHADS VAS score? Because that'll really change your inflection of whether you worry about those people. But we certainly always lean on our congenital cardiologists because they're so highly individualized. But that's kind of the key question we try to drill down on with them. For example, hypertrophic cardiomyopathy, we generally at our place consider equivalent to get you the C in CHADS VAS. Independent of whether or not you have any other risk factors, but just another layer of multidisciplinary care for those patients.
Any other questions from our EP guys?
Yeah, Bill, it's Derek.
Hi, Derek.
Great talk. Nice to hear you and see you. So fantastic talk. I guess the question I have, and I'm still struggling with this based on the data of ASSERT and some of the stuff you went over, is is it a marker of disease or is it the causative factor for stroke, atrial fib? And is it just another marker? Should there be a CHADS AF score, which AF counts for 10 points or something in that score in terms of choosing anticoagulation?
Yeah, I have spent a lot of time wondering the same question, and I think that at some point, right now we are on a pretty linear model of risk prediction, that if your CHADS VAS score is high enough, you get, it's one-dimensional. If it's high enough, then we say you need oral anticoagulation. I think at some point, we're going to need to get to a two-dimensional model where we're talking about your burden of atrial fibrillation and your CHADS VAS risk score, and maybe even three-dimensional if you think about the potential for things like histology and biomarkers. I think that eventually we're going to have to get to some model like that. The question is always, what will be the thresholds to establish benefit? And I think that's going to be likely to be really difficult. Now, Artesia, which I know you're familiar with, Derek, but some people may not be, is the randomized clinical trial that compares apixaban to aspirin in patients with device-detected atrial fibrillation of a duration of more than 6 minutes and less than 24 hours. If Artesia is positive all across the board, then we might not need to be so discriminant. But I know the aggregate event rates in Artesia, and they're relatively low. If Artesia comes out positive, then we're probably going to have a subgroup analysis that really shows that it's patients with longer duration. We're going to need to refine our risk stratification for those people, and it'll open up a whole new generation of research.
Yeah, no, I totally agree. And I guess the second part of that is, the 14 days of monitoring. I mean, Russell and a couple of our stroke colleagues completed a large randomized trial of implantable devices versus external monitoring for 30 days. Yeah. And the pickup for AF is dramatically different with longer term monitoring. So it's over 20% if you monitor long term versus, about 8% if you monitor short term. So, I mean, I think the 14 days is reasonable because that's what patch technologies allow you to do today. But I'm wondering are we basing that 14 days on what the technology offers or scientifically what makes the most sense?
Yeah, I think that a lot of it is based on the practicality. That 14 days just happens to be the upper limit of a practical, relatively small technology for continuous monitoring. Now, if what I've shown on the slides that's up right now works, then that actually might be quite useful. But I think that's why randomized trials are essential. The challenge is that because the population attributable risk of atrial fibrillation for stroke is at worst 15% and at best 30%, you need massive randomized clinical trials to show that you reduce the risk of stroke. And that's clearly what the U.S. Preventive Services Task Force showed. Now, in the International AF Screening Consortium, we're actually pre-specifying a pooled individual patient data meta-analysis of over 300,000 patients in about 15 different randomized control trials. I hope that we can kind of get to the bottom with that, and with using randomized data and individual patient data meta-analysis, it'll really open up the power of our subgroup analysis. The challenge is always that there's so many horses have left the barn in terms of what's happening for screening, and we haven't even touched yet on consumer sort of driven screening where patients go and screen themselves regardless. So there's a lot of work there to do to prove that this actually helps, and then pick off some cut points.
Bill,
great, thanks.
The question there.
Thank you.
Paul.
Bill, hi, great presentation, and thanks for coming to visit us. Congrats on your PhD. This is really interesting, and
thank you.
I'm glad to see somebody looking into cardiac surgery related atrial fibrillation, because as we discussed yesterday, there's not a lot of good data on this, and obviously we deal with it all the time in cardiac surgery. My question for you, and even to extend to the group, is what are your thoughts about, while these patients are convalescing on our wards and go in and out of AFib, how aggressive should we be about anticoagulating them while in hospital? And there's obviously different thoughts about this, and some people will, wait, if it's persistent for 24 hours or comes and goes for 24 hours, they may get aggressive with it. Other people are really lax about it. What are your thoughts about that? And is there any data to suggest that what they do in hospital is potentially predictive of later events?
Yeah. So in the cardiac surgery population, I'm not aware of any good data that help us guide those questions. But if we pull from atrial fibrillation data elsewhere, we know that the relationship between the temporal atrial fibrillation and actual stroke is actually relatively dubious. And I think that's a dogma that we got into, about 30 years ago. We also know, what we do know is that, the more days that you get out from surgery, the lower your bleeding risk is. Now, we've talked about this in Hamilton, and the relative consensus is that anticoagulation can start about 5 days out, because that's the point, just sort of by consensus, at which the bleeding risk is low enough that you can initiate oral anticoagulation. So I don't feel that it is a race to start and get them anticoagulated, particularly like the way you might feel with some other patients. But as soon as the bleeding risk starts to come down, then it might be reasonable. But that's really that's based on pulling from different populations and talking to my surgeon colleagues at home.
Okay, thanks.
Thank you.
Mitch has a question.
Yes.
Hi, Mitch.
Bill, great presentation. Thank you very much. The obvious end game of this line of research is take your 4 patients that you described at the beginning of your presentation and say which one of you guys has reversible AF that's not going to recur because you don't have an underlying atrial cardiomyopathy. I need to anticoagulate those people who have provoked AF because they have an underlying cardiomyopathy. They were going to get AF anyway at someday.
Yeah, I agree.
In that regard, what do you think are going to be the candidates? I'm sure you're already collecting data that's going to help us answer that question someday. What candidates have you already decided upon that you're following?
Yeah, so I think the candidates, and if you were to say, Bill, you've got all the money in the world, and thanks, Libin.
You have to move to Alberta for that.
Yeah, I know. That's that we're making the same joke. And that there's tons of equipoise, right? Then the population that I would want to put in a randomized clinical trial would be people with markers of atrial myopathy, such as intraatrial block when they have their 12-lead EKG, a left atrial size that's above the mean, people who had a antiarrhythmic treated duration of atrial fibrillation that went over 24 hours, and then people with Chad's VAS scores that I think are up over 4. I think there you would have an enriched population where it would be useful to test oral anticoagulation versus not. And if we can show a signal, it would be fantastic to be able to get some gene expression in that, really to enrich those people. And I think that the question, that you're asking builds very much close to what Derek said about what's the threshold sort of all those factors together. But that would be the population, that we can test in.
Well, in that regard, it's important to recall that Chad's VASC also predicts the future occurrence of atrial fibrillation.
Yes. And it's probably the best score to do that as well, and does so. It does so relatively modestly, but it is probably the best predictor that we do have. I agree.
So
thanks again.
Final thought there, Bill, because as you know, all these guys have pre-op ECGs. And
yes.
Great data from Mayo Clinic, and we're actually going to collaborate with them to look into some of these AI and machine learning models that can just look at the ECG and predict with a high sensitivity and specificity that these people have had or are going to have AFib. So I would say just don't discard the phenotype from the ECG and introduce it into the model.
Yeah, I think that's brilliant. You just want to make sure that it's been externally validated multiple times, because there's some funny AI stories that I know that at Duke, they had could look at an echocardiogram and predict death, but when they looked under the hood, they just realized it was sorted between inpatients and outpatients. So it's good to see more AI that are being the external validity AI by taking it into different settings, I think is critically important.
Well, it's fantastic.
Thank you.
Unfortunately, some people are asking if you can offer psychotherapy for the management of AFOS. What can MRI help? But it's 9 o'clock. I got another meeting, so you guys want to keep on chatting, that's fine. But I have to go to another meeting. So thanks again. Excellent talk.
Thank you. Thank you for having me.
We'll be in touch.
Bye-bye.
Bye-bye.
Oh, hey, Bill, it's Yorgo Vinhusen.
Hey, Yorgo.
I really enjoyed your talk.
Thank you.
A practical question. Your definition of atrial fibs, if I recall correctly, it said something about no visible P waves. I assume you mean no visible sinus P waves. How are you managing those arrhythmias where there is clear evidence of atrial activity but is not sinus? So atrial flutter, really fast atrial tachycardias, how are they being categorized?
Yeah, so that's a great question. So there's an algorithm that's built into the into ZO patches, right? And they are it relies primarily on a regularity of RR interval as the main thing to pick up atrial fibrillation. We do consider atrial flutter equivalent, and Jorge Wong leads a separate adjudication committee that actually reviews every EKG for things. So atrial tachycardia would actually be called atrial tachycardia because of some of the uncertainty, but flutter and fib are lumped together.
Okay, good to know.
Sounds like there are no more questions, Bill. We'll let you escape.
I think so. Awesome. Thanks, Mitch. Thank you, everybody, for coming.
Bye-bye.
Bye-bye.